Anamed itu pegang apa aja, Pak Amsen?
Anamed itu dok, kita ada stand dokter saat ini.
Oh, stent jantung.
Iya, tapi nge-sub sama orang di sini, produk dari lokal di sini. Kemudian nanti untuk ke depan ini kita masih ada produk-produk yang lain dari Intega Group dan cukup banyak dok.
Iya.
Iya dok. Nah yang pertama kita akan launching nanti itu produk Sedaconda ini dok di bulan Maret nanti, insya Allah.
Sedaconda, ya.
Iya dok.
Ya mudah-mudahan lah. Karena ini sesuatu yang baru ya. Dulu kita kan hanya pakai untuk kasus-kasus tertentu.
Iya dok, dok. Amin dok. Tentunya dengan bantuan dokter Bambang, bantuan dokter Olowan, kita
ya,
bisa.
Pada dasarnya kalau manfaatnya itu banyak pasti lah.
Iya dok, iya dok.
Makanya kita tunggu nanti dokter Kirsten ya.
Iya dok. Kirsten.
Banyak kerjamu itu nanti. Langsung. Jadi kau harus dekatin di mana rumah sakit. Karena sekarang rumah sakit daerah juga banyak dananya.
Iya, iya dok.
Kalau mereka mau melengkapi dengan benar, ya kenapa tidak? Iya kan?
Betul, betul.
Tapi itu sejak COVID itu, rumah sakit itu, waduh.
Hello. Hello.
Yep.
Hi, Ade.
Halo.
Hello.
Hello, Dr. Kerstin.
Okay, I think we should be getting ready. We are at 3:57 now.
We start now?
No, let's start at 3. Is that okay, Dr. Oloan?
Yep, because we are waiting for the president's opening speech,
Yes.
short speech.
Ade, I will leave that to you to introduce in the president of the society to open the meeting. Okay.
Okay.
Thank you.
Dokter Pujo, bisa dimulai sekarang barangkali ya?
Ya, bisa dimulai.
Ya,
tapi saya harus rapat.
Nggak apa-apa, Dok.
Mas Pujo, sibuk ya?
Ya, Dok.
Sibuk.
Ini sedang rapat pleno MKEK, Dok.
Oh, I see. Ayo, Dek, silakan.
Hello, everybody. Good afternoon. Thank you so much for being here. Let me begin by giving you a warm welcome to the PERDICI's webinar with the theme is the past and future trends in ICU sedation. And thank you so much for the sponsor to Anamed Company. First, let me introduce myself. My name is Ade. I am the Secretary Office of Indonesian Society of Intensive Care Medicine. And I would like to say hello to Dr. Kerstin and team from Singapore and Thailand. Hello, Dr. Kerstin. Hello, Laina. Thank you for joining us.
Halo.
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 Yang kami hormati Ketua PERDICI, Dr. Bambang Pujo Semedi, SPAN KIC, dan di sini juga telah hadir Dr. Oloan Edward Tampubolon, SPAN KIC, KNA MHKes, dan beliau nanti yang akan memoderatori acara ini. Kemudian hadir juga Dr. Bambang Wahyu Prayitno, SPAN KIC sebagai pembicara pertama, and Dr. Kerstin Dennis from German as a second speaker. Acara ini akan diakhiri dengan sesi tanya jawab dari peserta melalui kolom Q&A. Untuk itu, seluruh pertanyaan yang diajukan pada kolom Q&A mohon menggunakan dalam bahasa Inggris. Begitu juga di media YouTube, kalau bisa peserta seluruhnya menggunakan bahasa Inggris. Dan bagi peserta yang belum bisa masuk ke dalam webinar Zoom, silahkan mengikuti registrasi melalui link YouTube PERDICI Official. Dari sana pun kami telah siapkan juga linknya sehingga kami tetap bisa mendata kehadiran seluruh peserta di YouTube tersebut. Before we start this webinar, please watching this video. Rizka, silakan. Terima kasih Rizka. Pertama-tama kami persilahkan kepada Ketua PERDICI, Dr. Bambang Pujo Semedi, SPANKIC, untuk memberikan opening remarks-nya pada acara ini. Waktu dan tempat kami persilahkan.
Baik, terima kasih. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore. Salam sejahtera bagi semua. Pertama-tama saya ucapkan selamat datang pada seluruh peserta yang hadir dalam forum ini. Pada yang terhormat Dr. Bambang Wahyu dan Dr. Oluan yang telah bersedia meramaikan forum ini. Ini adalah suatu forum yang saya kira sangat penting ya, karena kita membahas tentang sedasi di ICU. Dan banyak sekali simpang siur dalam sedasi ini sehingga bisa menyebabkan masalah pada berbagai perawatan pada pasien-pasien ICU. Marilah pertama-tama kita panjatkan puji syukur atas kehadirat Tuhan Yang Maha Esa yang telah melimpahkan rahmat dan hidayah kepada kita semua, sehingga pada hari ini kita semua dapat berkumpul dalam suatu forum. Karena forum ini kami harapkan merupakan sumbangsih PERDICI untuk meningkatkan wawasan keilmuan, terutama dalam bidang intensive care. Karena bidang intensive care ini sejauh ini sudah sangat berkembang begitu jauh, banyak peralatan canggih yang semuanya bertujuan untuk meningkatkan kualitas perawatan pada pasien-pasien kritis. I would like to welcome Dr. Kerstin Dennis Rom, who has taken the time to join us this afternoon. Thank you for being willing to share your knowledge and experience, maybe about sedation in ICU. Hopefully it can open our horizon to providing sedation to critically ill patients in the ICU. Thank you very much. And a big thank you to PT Anamed Sejahtera Pharma for providing support so that this event can be held properly, and hopefully the collaboration can continue in the future and can provide benefit for medical field, especially in the critical care area. I think the sedation is in the core part of management in ICU patient, and improper sedation will produce adverse effect for the patient. Therefore, the management of sedation in ICU patient must be rational and meet the proper scientific principles. And hopefully today's discussion will provide knowledge about proper sedation in ICU patient. On behalf of PERDICI, I would like to welcome all participants and speakers who have attended this forum. Hopefully this event will provide benefit for us. Thank you very much.
Terima kasih Dr. Pujo atas opening remarks-nya, dan kemudian selanjutnya kami persilahkan kepada Dr. Oluan Edward Tampu Bolon, SPANKIC, KNA MHKes, untuk memimpin webinar ini, memoderatori. Silahkan dokter, untuk waktu dan tempat kami persilahkan.
Terima kasih Mbak Ade. Selamat sore audiens yang berbahagia di akhir pekan ini dan masih bangun, karena kita mau berbicara mengenai sedasi. Dr. Bambang Wahyu akan mempersembahkan gambaran-gambaran yang kita pakai selama ini di negeri kita tercinta ini, dan ada sumbangan dari kolega kita dari Jerman yang mau sharing dan barangkali bisa kita manfaatkan ke depan. Pilihan ada pada kita. Saya cuma mau menambahkan, ikuti saja dengan baik. Video tadi sudah mengantar untuk banyak pertanyaan. Tolong pertanyaannya ditulis saja. Kalau buat Dokter Bambang bahasa Indonesia jadi langsung bisa diseleksi. Yang buat Dokter Kerstin nanti dalam bahasa Inggris. Kalau sampai membutuhkan translation ke dalam bahasa yang perlu kesulitan, barangkali saya bisa bantu. Jadi kita segera mulai saja. Dear Kerstin, like to welcome you now in English, not in German. They're from Ludwigshafen. There's a different weather than here, but intensive care is everywhere in the country. So I give you a warm welcome, and please listen. Dr. Bambang will present his presentation in Bahasa Indonesia, but his slides are in English. Bro, silakan bro. Silakan Dr. Bambang, semua sudah kenal.
Terima kasih Dr. Oluan atas pengenalannya untuk saya. Saya ucapkan pertama terima kasih pada panitia yang telah mengundang saya untuk berbicara mengenai sedation pada saat ini di ICU. Jadi saya ucapkan pertama kali juga selamat datang pada Dr. Kirsten yang telah bersedia untuk berbicara di sini. Dr. Kirsten berasal dari kota yang dulu saya pernah tinggal di sana selama setengah tahun di Mannheim untuk belajar bahasa. Beliau di Ludwigshafen, ya, jadi tidak begitu jauh dari Mannheim. Saya diberi topik mengenai current station practice untuk ICU untuk pasien yang sakit kritis. Jadi pertama-tama tentu kita timbul pertanyaan, kenapa sih kita mesti bicara mengenai sedasi di ICU? Karena pasien di ICU itu tidak bisa lepas dari 3 hal, yaitu nyeri, agitasi, dan delirium. Kenapa demikian? Kita lihat salah satu studi yang cukup lama, ini tahun 96, di Intensive Care Medicine Journal, di mana ada 50 pasien ICU mendapat ventilasi mekanik, kemudian ditanya pengalamannya pasien tersebut, apa yang dirasakan selama mendapat ventilasi mekanik, dan juga ditanya pada dokter maupun perawat dan keluarganya yang dirawat, pasien yang dirawat. Apa yang dirasakan paling tidak enak selama mendapat ventilasi mekanik? Ternyata menurut pasien, ranking pertama itu yang paling dikeluhkan adalah perasaan nyeri. Ya, nyeri itu paling dirasakan oleh pasien, padahal dia tidak dalam pembedahan, tidak pasca trauma, semuanya pasca trauma. Kedua, ranking kedua adalah tidak dapat tidur. Ya. 3, adanya pipa di dalam lewat hidung atau mulut. Yang keempat, rankingnya adalah tidak berdaya apa-apa karena terikat pada banyak selang. Ini menurut pasien. Menurut keluarga pasien sama. Ternyata ranking pertama adalah nyeri. Menurut tim yang merawat, kelihatannya merawat ini pasiennya memang seringkali merasa nyeri. Jadi ranking pertama itu diduduki oleh semua berpendapat bahwa itu karena nyeri. Ya. Jadi ini menjadi dasar bahwa orang yang diberi ventilasi mekanik ini menderita, sangat menderita. Jadi kalau kita mengabaikan hal ini, kita berarti sebagai dokter kita itu lalai. Karena apa? Tugas dokter adalah to preserve life. Yang kedua adalah to alleviate the suffering. Nah, dokter anestesi, apalagi dokter ICU juga, Itu tugasnya memang menyelamatkan nyawa. Yang kedua adalah mencegah atau mengurangi penderitaan. Itu tugas utama dari seorang dokter. Jadi, nah di Indonesia ini rasanya ini agak dilalaikan. Atau bahkan sebagian malah berlebihan mungkin. Ditidurkan sehingga berhari-hari, berminggu-minggu masih ditidurkan. Karena apa? Supaya tidak dipanggil-panggil ya. Tapi mari kita lihat apa efeknya kalau terjadi keadaan gini atau justru karena tidak mau direpotkan ditidurkan berat. Ya, ternyata sebagian pasien itu mengalami keadaan yang disebut delirium. Ya. Dan selama mereka mendapat perawatan di ICU, dikatakan bahwa ini contoh dari penelitian Eli ini dari Amerika, bahwa ada di sini 200 lebih pasien, ternyata 41 pasien tidak mengalami keadaan yang disebut delirium. Delirium itu dulu kita sebut sebagai psikosis eksogen, tapi namanya sekarang resmi adalah delirium menurut Asosiasi Psikiatri di Amerika. Dan yang mengalami delirium sangat banyak. Ya, lebih dari 4 kali lipat ya. Mereka mengalami delirium. Dan delirium ini mortality-nya ini sampai 63% dibanding mereka yang hanya mengalami tanpa mengalami delirium. Begitu juga lama rawat inap di rumah sakit, itu juga jauh lebih lama bagi mereka yang mengalami delirium. Ya. Juga post ICU stay-nya. Jadi 3 kali lebih banyak risiko kematian dalam 6 bulan pertama. Mengalami masa rawat di rumah sakit lebih lama, juga di ICU, dan 9 kali lebih ada kemungkinannya harus mengalami long term neuropsychological atau cognitive dysfunction. Jadi konsekuensinya mereka yang mengalami dulu disebut sebagai psikosis eksogen, sekarang itu delirium, itu sangat besar. Nah, kita lihat ini adalah dari penelitiannya Eli tadi, kita melihat bahwa survival mereka yang tidak mengalami delirium itu lebih tinggi dibanding yang mengalami delirium. Juga hospital length of stay-nya, ini dari penelitian dia. Nah, ini penelitian yang lain dari OIMED, itu juga begitu, bahwa mortality dari mereka yang mengalami delirium itu survivalnya itu lebih rendah dibanding yang tidak. Ya. Juga delirium impact-nya pada mortality kalau dia disertai koma juga. Jadi ini mengharuskan kita sekarang di ICU yang dulu tidak terlalu berpikir mengenai masalah itu, harus berpikir betul-betul. Banyak sekali pasien mengalami delirium, dan delirium itu biasanya suatu tanda bahwa dia akan mati. Nah, ini ada penelitian lain ya, di mana dari penelitian dari ini dari 16.000 pasien, sepertiga, kira-kira 31,8% itu dari 42 studi, ini dari meta-analisis, itu mengalami delirium. Ya. Dan mortality-nya juga sangat bermakna, ya, berbeda. Jadi lagi-lagi kita harus berhati-hati merawat pasien. Ini kita lihat mortality-nya yang mengalami mortalitas pada mereka mengalami delirium lebih berbeda bermakna dengan yang tanpa delirium. Juga length of stay-nya di ICU, juga di rumah sakit length of stay-nya, dan waktu lama atau mereka dalam mechanical ventilation itu lebih lama. Dan ini lagi-lagi kita seringkali tidak menyadari. Nah, dari fakta mengenai delirium ini, kita bisa melihat ini dari fakta bahwa di Amerika 55.000 pasien, ini penelitian yang cukup lama ya, dirawat tiap hari di 6.000 ICU kebanyakan mendapat mechanical ventilation. 60-80% dari pasien tersebut mengalami delirium dan 20-50% juga mengalami delirium ya, dari yang lower severity, yang penyakitnya itu tidak terlalu berat. Jadi 3 kali lebih besar mereka itu akan mati dalam waktu 6 bulan pertama. 5 kali ventilator D-nya itu lebih rendah bagi yang tidak mengalami delirium, dan yang mengalami delirium 9 kali insiden terjadinya gangguan kognitif setelah discharge. Ya. Dan biaya yang dihabiskan itu 15.000 sampai 25.000. Kosnya lebih tinggi dari yang tidak mengalami delirium. Dan itu per tahun itu kira-kira 16 miliar dolar di Amerika. Jadi bukan main besarnya. Dan jadi critical illness itu akan pada pasien mungkin akan memerlukan ventilasi mekanik, mungkin mendapat obat-obatan untuk penenang, ya, psychoactive medication. Mungkin dia akan mengalami gangguan tidur, mungkin dia akan mengalami delirium, dan mungkin mereka akan mengalami post traumatic stress disorder, seperti orang yang habis perang di Vietnam ya dulu, functional impairment, cognitive impairment, dan kematian. Ini risiko yang tidak boleh kita pandang rendah. Jadi berbagai faktor menunjang terjadinya nyeri dan mengakibatkan kecemasan dan delirium. Dan intervensi biasanya yang diberikan adalah sedatif, analgesik, antipsychotic medication, pengelolaan penyebab, dan targetnya kita harus mencapai ini. Tidak boleh terlalu berat, ya, karena menyebabkan menjadi unresponsive, otot-otot nafasnya atrofi, menderita VAP dan lain-lain, itu efek sampingnya. Tidak boleh terlalu ringan karena akan menyebabkan gangguan juga. Ya. Jadi kalau kita melihat di sini sangat kompleks, yang bisa menyebabkan terjadinya delirium tersebut. Kalau pasien mengalami nyeri, mengalami kegelisahan, agitasi, dan memerlukan sedasi. Sedasi itu sendiri bisa menyebabkan delirium. Ya. Kalau tidak diberikan dengan tepat. Sehingga kita lihat di sini ini saya ambil dari majalah Wall Street Journal, ya, koran Wall Street Journal tahun 2011. Di sini dikatakan bahwa ada perubahan di ICU, ya, di intensive care untuk memperbaiki outcome setelahnya. Ya, karena sudah lama pasien itu biasanya di ICU diimobilize, disedasi dengan berat, dapat ventilasi mekanik di berbagai ICU, tapi di berbagai ICU yang lain itu justru tidak diapa-apakan, padahal mereka stres, tetapi ini dapat men-trigger terjadinya delirium. Pemberian sedasi yang berlebihan menyebabkan delirium, tapi yang kurang juga akan menyebabkan delirium. Dan ini sekarang mulai disadari dan diusahakan untuk diubah. Jadi ini perubahan di ICU. Dan kalau kita lihat hyperactive sedation, ini merupakan salah satu bentuk di mana delirium ini akan terjadi. Orangnya hiperaktif, berontak, mungkin bisa membahayakan dirinya sendiri atau orang lain. Ya. Dia ini gampang dikenali, ya, dan ini kira-kira 1,6% dari seluruh episode delirium. Biasanya pada mereka yang usianya itu lebih muda, ya. Tetapi pada orang-orang yang tua, manifestasi deliriumnya itu berbeda. Kebanyakan hipoaktif, di mana mereka itu menarik diri, menjadi diam, paranoid, ya. Ini seringkali disebut sebagai quiet delirium. Kelihatannya oke-oke saja, dia diam, tidak berontak, tapi ini justru terbanyak, salah satu yang terbanyak, yaitu 43,5% dan justru biasanya pada orang tua. Dan yang campuran yang paling banyak itu 54,9%. Ini justru prognosisnya lebih jelek. Kadang-kadang dia hiperaktif, kadang-kadang dia hipoaktif. Jadi ini yang terjadi. Jadi ini adalah gambaran grafisnya. Jadi pasien yang berumur 65 dan lebih tua itu mengalami hipoaktif delirium pada frekuensi yang lebih banyak daripada orang yang muda, yang hanya 1, sekian persen. Dan ini justru kadang-kadang kita harus perhatikan. Kita menganggap bahwa oh dia tua, dia sudah tua, dia nurut aja, wah bagus. Padahal itu tidak bagus. Ya. Jadi kita harus membedakan antara dua keadaan itu, yaitu koma dan delirium. Bedanya ya apa? Biasanya kalau koma itu tidak bisa dibangunkan. Tapi kalau delirium itu bisa. Tapi ada perubahan-perubahannya. Dia mengalami disorganized thinking, status mentalnya itu naik turun, perubahannya terjadi akut, seringkali acuh tak acuh, dan seringkali juga mengalami halusinasi, delusi, atau ilusi. Ini biasanya orang ini mengalami delirium. Dan kita malah menyatakan, oh Pak itu seringkali dia melihat ada anak kecil, hantu kecil, main-main lari-lari di ICU. Itu sebetulnya dia mengalami delirium. Karena sebetulnya tidak ada. Tapi itu yang dirasakan oleh dia. Dan salah satu penelitian lagi di sini disebutkan bahwa intervensi antara yang dilakukan pasien yang dengan mechanical ventilation diberikan obat-obatan, ini kejadian deliriumnya menjadi lebih kecil. Time di ICU dengan delirium juga menjadi lebih kecil dan lain-lainnya. Dan ternyata memang menguntungkan pemberian sedasi selama itu diberikan dengan tepat, dosis tepat, waktunya tepat. Itu akan terjadi begitu. Nah, karena itu kemudian melihat keseriusan keadaan delirium ini dan bagaimana cara mengatasi yang mungkin relatif sulit, maka Society of Critical Medicine di Amerika itu mengadakan pertemuan dan membuat suatu guideline yang disebut sebagai awalnya tahun 2013 disebut sebagai Pain, Agitation, and Delirium, ya. Jadi ini untuk Pain, Agitation, Delirium. Karena itu dulu disebut sebagai PAD. Guideline bagaimana mengelola pasien dengan PAD. Pain, Agitation, dan Delirium ini tidak bisa dipisahkan. Karena apa? Seringkali awalnya itu terjadi karena pain, karena tidak diatasi dengan baik, timbul agitasi, dan akhirnya menuju ke delirium. Nah, ini kemudian pada tahun 2018 diperbarui lagi, 5 tahun kemudian, keluar yang kedua, tapi ditambah immobility dan sleep disruption. Jadi gangguan tidur itu mungkin merupakan awal dari terjadinya itu. Immobility dan gangguan tidur. Karena itu dimasukkan jadi satu, sehingga namanya diubah menjadi pain, agitation, sedation, delirium, immobility, dan sleep disruption. Dan disingkat sebagai PADIS. P-A-D-I-S. Ya, PADIS. Nah, jadi karena itu pasien di ICU kemudian dianjurkan untuk dimonitor. Pertama adalah pain. Harus dimonitor memakai suatu yang bisa diukur, yaitu bisa self-reporting dengan numerical rating scale atau Wong-Baker Faces Pain Rating Scale. Ini lebih baik ya, daripada kalau kita yang menilai. Jadi ini adalah berdasarkan keluhan pasien, jadi self-reporting. Itu bisa, kalau pasien dengan intubasi misalnya, dia tidak bisa berbicara atau critically ill, maka kita bisa menggunakan cara lain yang disebut sebagai BPS, bukan Bambang Pujo Semedi ya, tapi Behavioral Pain Skill. Atau cara lainnya adalah CPOT, Critical Care Pain Observation Tool. Kalau kemudian dia dengan nyeri itu sudah diatasi, tidak ada rasa nyeri, skalanya baik, tetapi dia mengalami agitasi, maka itu diperlukan sedasi. Tetapi ini juga harus dinilai sampai berapa skalanya. Apakah dia memerlukan sedasi atau tidak. Dengan bisa menggunakan yang dianjurkan adalah RASS score atau Riker SAS ya. Dan kalau dibiarkan kemudian dia berlanjut bisa menjadi delirium, di mana bisa dievaluasi dengan CAM ICU score atau dengan ICD-SC ya. Ini untuk menilai kalau pasien dalam keadaan delirium. Nah, ini adalah algoritma yang digunakan untuk menilai itu. Saya kira saya tidak mungkin menjelaskan semuanya karena waktunya juga terbatas. Tapi di sini kita bisa melihat selalu yang didulukan adalah bagaimana pain-nya, baik atau tidak. Ya, jadi kalau tidak itu diatasi dulu dan diatasi dengan obat-obatan tertentu yang anti nyeri, tetapi sedapat mungkin kalau bisa juga mempunyai efek sedasi. Itu yang dianjurkan, antara lain adalah opioid yang digunakan karena dia mempunyai efek sedasi juga. Ya. Dan kemudian kalau terjadi delirium, ini adalah algoritmanya. Ada beberapa algoritma, tapi ini salah satunya ya dibuat oleh Redier. Ya. Nah, kemudian kalau salah satu tujuannya kemudian adalah kalau mungkin sedapat mungkin pasien itu bisa lepas dari ventilator kalau pakai ventilator. Karena itu dulu ada namanya daily sedation, puasa sedasi setiap hari. Nah itu kalau pasiennya diberi analgetika dan sedasi, sedasinya membuat tidur. Sehingga kalau tidur susah dilakukan weaning atau lepas dari ventilator. Karena itu cara yang dilakukan adalah kita harus melakukan SAT dulu, Spontaneous Awakening Trial. Kalau itu berhasil, jadi ini ada kriterianya ya. Pertama tentunya pasien harus dipastikan dulu sudah penyakit yang menyebabkan dia harus diventilasi mekanik sudah teratasi. Kemudian dilihat dia memenuhi syarat enggak untuk dilepas sedasinya. Jadi harus dibangunkan, awakening, dibangunkan. Nah, apa persyaratnya? Tidak ada kejang, tidak ada dalam alcohol withdrawal syndrome dan lain-lainnya ini. Jadi apa? Kalau sudah begitu memenuhi syarat untuk dilakukan stop sedasi, maka stop sedasinya, di stop. Tetapi tidak berarti pasien sudah di stop, dibiarkan begitu saja. Dilihat apakah dia kemudian kembali gelisah. Caranya apa? Ini ada parameternya. Kalau terjadi anxietas, agitasi atau nyeri, respiratory rate-nya meningkat, SpO2 menurun, respiratory distress, akut kardiak aritmia, maka berarti pasien ini gagal dilakukan penghentian obat sedasinya. Nah, kalau begitu berikan lagi sedasinya. Tapi jangan diberikan penuh, karena tadinya diberikan penuh, dia tenang-tenang saja. Berikan setengah dosisnya saja. Nah, kemudian besok diulangi lagi. Tapi tentunya dengan dosis sekarang yang sudah tinggal separuhnya. Kalau dia dengan separuhnya ini baik, maka dicoba lagi besoknya. Tiap hari dilakukan. Ya. Kalau tidak berhasil, kembali lagi. Tapi separuh dari separuh tadi dosisnya. Kalau berhasil, maka oke, bahwa dia berhasil, dihentikan, sudah berhasil, maka dilihat apakah dia layak untuk dilepas dari dihentikan ventilatornya. Persyaratannya apa? Screeningnya. Tidak ada agitasi, oksigen saturasi, dan lain-lainnya ini. Ya. Kalau ini memenuhi syarat, maka pasien dilakukan spontaneous breathing trial. Dan kalau dia berhasil, maka pertimbangkan untuk ekstubasi. Tentunya persyaratan ekstubasi juga harus dipenuhi. Ya. Tapi kalau tidak berhasil, dikembalikan lagi ke sini atau ke sini. Ya. Jadi itu dengan demikian yang dulu dalam sepsis campaign itu dikatakan bahwa tiap hari harus dilakukan puasa sedasi, harus dicoba weaning tiap hari. Inilah caranya, seperti ini. Jadi tidak sembarangan, pokoknya, wah menurut saya kelihatannya baik-baik aja dia weaning. Tidak, ada parameter-parameter yang harus dipenuhi, ada tanda-tanda di mana dikatakan tidak berhasil, sehingga pasien itu ini keamanannya itu dijaga. Demikian juga untuk waktu weaning. Ini adalah cara SAT, SPT. Dan kemudian di dalam penanganan pasien yang mengalami PAD tadi, gangguan yang bisa menyebabkan delirium, itu seringkali banyak faktor penyebabnya. Ya, pasien, predisposing faktor penyakit, ya, lingkungan yang terang benderang atau tidak pernah dijenguk, ribut seperti keadaan di ICU yang selalu, pasien yang mengalami penyakit-penyakit akut seperti ini cenderung semuanya itu menyebabkan delirium. Ya. Tapi faktor-faktor yang di sini itu lebih mudah diubah, dikendalikan dibanding faktor-faktor yang ini, seperti pengguna alkohol, usia tua, itu kita tidak bisa merubah apa-apa, ya, atau sulit diubahnya. Tetapi faktor ini kalau bisa dikurangi. Nah, kita tahu antara lain biarkan orang itu kalau siang itu jaga, kalau malam tidur nyenyak. Jadi faktor-faktor ini dikurangi. Kita tahu kalau salah satu maskapai penerbangan yang paling terkenal di dunia itu adalah SQ. Dan SQ itu kalau kita naik, begitu naik kita diberi tutup mata, diberi kaos kaki supaya hangat, dan diberi tutup telinga. Ini sebenarnya untuk mengurangi, jangan sampai kita itu terganggu oleh lingkungan. Jadi ini suatu usaha baik-baik, dan itu memang harus dicoba untuk mencegah delirium. Antara lain ini adalah non-drug atau non-pharmacological. Ini kita harus bisa menyediakan. Nah, tapi kemudian dari beberapa studi, ya dari ini studi meta-analisis dari PubMed, ya, dilakukan pemeriksaan yang lain, yaitu dengan polisomnografi. Apa itu? Nanti kita singgung. Dari 38 studi, konklusinya apa? Karena dengan polisomnografi itu semacam EEG yang digabung dengan pulse oximeter, digabung dengan elektromiografi dan pergerakan okulo mata. Jadi sana orang bisa menilai sedasi, tingkat kesedasi pasien itu sampai dengan lebih teliti. Tetapi tentu ini tidak bisa karena ini alatnya itu khusus, tidak praktis dan memerlukan orang yang ahli. Tetapi dari alat ini, dari penelitian diketahui bahwa pemberian sedasi itu tidak boleh terlalu berat, harus minimum, ya. Tapi cukup setiap hari kita bisa melakukan puasa dan lain-lain, puasa sedasi. Jangan berikan lingkungan yang kalau bisa mengganggu pasien tidur, noise minimum, dan beberapa mood yang mungkin bisa membantu, mood mechanical, mode of ventilation, ya. Nah, karena apa? Ternyata tidur ini, kalau terjadi gangguan tidur, ini menyebabkan ansietas, nyeri, depresi, kognitif dysfunctionnya turun, gangguan respirasi, gangguan kardiovaskuler, gangguan imun sistem, dan metabolisme. Jadi orang sekarang juga melihat lebih dalam. Tidak cukup sekedar tidak nyeri dan dia diatasi gelisahnya, tetapi jangan sampai tidurnya itu terganggu. Itu sampai segitu. Dan ini baru, ini hal-hal yang baru yang mulai dekade terakhir ini dicoba untuk diatasi lebih lanjut, diteliti lebih lanjut. dan sekarang masih dalam penelitian. Jadi karena apa? Karena orang yang terganggu tidurnya, efeknya begitu bermacam-macamnya, yang juga obat-obat yang kita berikan itu bisa mengganggu tidurnya sedemikian rupa sehingga justru bisa menyebabkan delirium. Itu yang terjadi. Nah, sehingga ini adalah gambaran paling mudah adalah tidurnya. Tidur orang normal itu mempunyai pola EEG yang tertentu. Ya. Di mana ada REM, ada tahap-tahapnya, tahap 1, 2, 3 dan lain-lainnya. Tetapi ya, quality dan quantity dari tidur itu penting. Kalau itu terganggu, maka akan mengganggu dan dapat menyebabkan delirium. Dan orang yang sakit di ICU, termasuk ini relawan yang dicoba untuk diam di ICU, itu ternyata mengalami gangguan tidurnya. Baik siang hari di mana orangnya itu jaga biasanya, dia bisa tidur, tetapi tidurnya itu bukan tidur yang normal. Demikian juga pada masa dia tidur, tidurnya juga tidak normal. Jadi ini dapat menyebabkan psychological distress, gangguan keselamatan dia yang mungkin menyebabkan kematian, dan recovery-nya itu menjadi terbatas dan quality of life-nya setelah keluar itu menjadi lebih parah. Ya. Ini adalah sekarang yang digunakan. Ini yang paling biasa, subjektif clinical observation. Kemudian survei dengan menggunakan Richard Campbell Sleep Questionnaire. Ini questionnaire aja, pastinya ditanya tidurnya bagaimana. Kemudian actigraphy. Ini menggunakan peralatan accelerometer, jam, lepas filter dan lain-lainnya, seperti komputer aja, seperti HP aja ya. Ya, HP sekarang, jam elektronik sekarang juga mempunyai alat yang semacam ini ya. Kemudian dengan bispectral index, kita sebagai anestesis biasanya sudah biasa mungkin dengan ini, tentunya di rumah sakit yang besar. Ya. Kemudian yang digunakan untuk penelitian sekarang ini adalah polisomnografi, yaitu menggunakan multiparametric test, yaitu EEG, elektrookulografi, EMG, EKG, SpO2. Jadi cuma ini impractical ya, dan memerlukan skill orang dan pengetahuan yang cukup sehingga tidak praktis hanya untuk penelitian. Nah, ini adalah salah satu contohnya. Ini adalah buatan Massimo, kecil ya, tapi digabung dengan yang lainnya. Ya, jadi Anda lihat di sini ada EEG, EMG, ya, kemudian ini seperti BIS ya, BIS monitor. Dan kemudian dari situ kita bisa menilai bagaimana tidurnya. Ya, kemudian kita bisa memberikan dosis obat yang seoptimal mungkin. Ini adalah anjuran yang guideline yang dikeluarkan terakhir tahun 2018 ya, yaitu ABCDEF, yaitu terdiri assess, both SFT dan SBT. Pilihan sedasinya, ini parameter apa yang diperlukan, delirium monitoring dan manajemen dengan cara ini, early mobility dan exercise dengan ini, ya, dan melibatkan family. Ini adalah yang sekarang disebut sebagai ICU liberation. Jadi bagaimana mengusahakan supaya pasien yang sakit kritis itu secepat mungkin keluar dari lingkungan ICU dan perawatannya yang mungkin bisa menyebabkan dia menjadi delirium dan kematian akhirnya, termasuk diantaranya adalah sedasi. Dan ini adalah salah satu contoh di mana kalau dilakukan bundle yang disebut sebagai ICU liberation bundle, kalau makin tinggi compliance-nya untuk mengikuti bundle tersebut, maka survival-nya makin baik. Ya. Juga di sini kita melihat delirium free and coma free days. Berarti dia lebih cepat sembuh dari deliriumnya dan komanya. Dan hospital survival-nya menjadi makin tinggi. Demikian juga delirium free dan coma free days-nya makin tinggi. Ya, makin banyak dilakukan, makin patuh dilakukan, makin baik survivalnya. Ini adalah hasil yang yang akhir-akhir ini dimulai digunakan. Nah, ini adalah juga begitu salah satu contoh di mana dikatakan dengan menggunakan ABCDEF bundle itu, maka dapat memperbaiki survival, mechanical ventilation use-nya menjadi lebih cepat dilepas, komanya lebih cepat bangun, deliriumnya juga cepat diatasi, tidak perlu pakai pengikat lagi, orang harus diikat, dan kemungkinan readmisi di ICU dikurangi, dan kemungkinan post ICU discharge itu menjadi lebih besar. Dan ini adalah penggunaan ini sejauh ini yang sudah diketahui dampak atau impact dari implementasi dari ICU Deliberation Bundle ini adalah menurunkan 72% ya, next day and mechanical ventilation, ya, menurunkan hospital death dalam waktu 7 hari sebanyak 68%, 65% menurunkan kemungkinan koma atau dia menjadi terbangun kembali, 63% penurunan dari penggunaan restrain, dan 46% penurunan dari readmisi di ICU, 40% penurunan dari delirium, dan 36% kemungkinan akan lebih cepat kembali ke rumah. Jadi ini kalau berlaku ya, apa yang biasa disebut sebagai Goldilocks Principle. Jadi memberikan sedasi itu harus demikian rupa, not much, not too much, jangan terlalu berlebihan, not less ya, jangan terlalu kurang, tetapi just right. Karena itu dalam sedasi itu berlaku sedation without depression. Saya kira ini suatu ungkapan yang mudah. Jadi harus dilakukan titrasi, jangan sampai under sedasi, jangan lagi over sedasi. Titrasinya terhadap pain, agitation, dan delirium, PAD. Ya. Tujuannya mengurangi nyeri, menurunkan ansietas, memanage delirium, mengurangi amnesia, dan recovery. Jadi saya percepat saja. Jadi ini adalah jalannya. Kalau kita memulai pasien masuk ICU, usahakan menuju natural cycle, ya, promote natural sleep cycle, perbaiki lingkungan sampai pasien itu tujuannya akhirnya mengurangi nyeri, menurunkan ansietas, mengelola delirium, amnesia, dan recovery-nya jadi lebih baik. Dan ini adalah algoritma yang lengkap dari San Diego Patient Safety Council. Saya kira ini baik sekali karena apa? Di sini mulai dari awal dilihat apakah pasien ini kalau bisa ventilatornya cepat segera, dilepas segera, maka dia masuk ke SAT dan SPT. Kalau dia masih nyeri atau lain-lainnya perlu ventilator lebih lama, tetapi dia merasa nyeri sesuai penelitian yang slide yang pertama saya tunjukkan, maka cara mengelolanya seperti ini. Dan kalau setelah ini dikelola semuanya baik, non-verbal pain scale-nya di bawah 2, ternyata pasiennya tetap gelisah, agitasi, maka diperlukan sedasi. Dan kalau kemudian justru timbul disorganized thinking dan lain-lainnya, terjadi delirium, maka dikelola secara baik. Saya kira itu yang bisa saya sampaikan secara singkat. Jadi kita diharapkan mengimplementasi ICU Liberation Bundle untuk memperbaiki outcome, memonitor dengan cara monitor mengatasi nyeri, yaitu analgesia first, ya, baru kemudian sedasi. Artinya analgesia sekaligus sedasi dengan obat-obatan itu antara lain opioid. Kemudian titrasi, sedasi, medikasi menggunakan validated assessment tool, ya, seperti skor yang tadi, ya. Dan tujuan kita adalah mencapai sedation without depression dan pertimbangkan penggunaan non-pharmacological approach, ya, untuk memperbaiki tidur. Dan ini berarti merubah total seperti ICU di Indonesia, ya. Dan studi mengenai penggunaan pengukuran yang lebih objektif itu sekarang masih diteliti. Mudah-mudahan alatnya itu nanti akan menjadi makin kecil, makin mudah dipakai. Dan terima kasih atas perhatiannya. Mudah-mudahan itu berguna sebagai pengantar ceramah selanjutnya oleh Dr. Kerstin. Terima kasih atas perhatian Anda. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Terima kasih banyak Dr. Bambang Wahyu untuk penyegaran dan updating mengenai berita-berita terakhir. Teman-teman audiens, silahkan. Pasti ada yang nyangkut, yang mau ditanya. Silahkan ditulis, karena Dr. Bambang sementara pembicara berikut ini akan membaca dan akan mencoba jawab teks pertanyaan Anda juga. Nanti di pertanyaan bersama bisa lebih lanjut lagi kita lakukan. Makasih, bro. Dear Dr. Kerstin, time is yours now. You heard, you heard, but you didn't understand. Sorry.
It was my first lesson in Indonesian, that's for sure.
Great. Immer, da muss man ja an erste Zeit nein, ne? But from the slides you see it's updated and there will be questions. So you come in now where those pointers, I know you are warm up already. You are going to tell us a little bit from your experience. You just came back from Dubai. You got your breakfast. I hope you got time now for us. Bitte sehr.
Okay. Okay. So I'm sure now you see my presentation.
Yep.
Yeah.
Okay, thank you. Thank you very much for your very warm welcome to be part in this webinar. I have actually never been to Indonesia, so that was really a pleasure to be invited and to be with you here today. First of all, these are my disclosures. Of course, I got honorary for talking from several pharmaceutical companies. And just to get you an idea where I'm sitting now, we have around 1 degree and not really snow in my area because it is one of the warmest areas. It's actually here in the southwest part of Germany. We are a city with a big industry, the chemical company BASF, most people know about it. This is where the main site is. We are directly at the River Rhine. And we have a very nice country that you can see here, countryside with vineyards, a lot of vineyards, and we know for white wine. That is the Riesling that is really known all over the world. I'm actually working in the St. Mary and Anna Hospital, which has 500 beds, and we have a 16-bed ICU, and we can equip 4 beds with inhaled sedation. So this is my background. And today I'm going to talk about volatile anesthetics, how Sedaconda ACD can be used in the ICU, and critically ill patient for inhaled sedation, which patients groups. Actually, we have heard a lot about sedation here from Dr. Bambang. Actually, we have come to an understanding that we need to have an individualized protocol, a protocol that we face our patient directly, that we see what he needs, if he needs no sedation, light sedation, and we have several tools and should apply a protocol. And why would I consider volatile anesthetics for sedation? Actually, I'm an anesthesiologist, so I'm very much used to use volatile anesthetics. In 1846, we have the famous ether ray, where we first used ether in a patient for operation. But it was more than 100 years when we started developing other drugs that were halogenated, that were not corrosive to the ventilators or to any plastic materials, and they did not do any harm to the patients. So the sedation we are using, the volatile anesthetics we are using nowadays are these 3 components. It's isoflurane, sevoflurane, and desflurane. And desflurane is a special agent because it's already boiling at normal temperature and it has a very low potency. So usually this is not a drug that you use very much in the ICU. And Of course, if you want to use it, it's possible, but you're going to have like 5 and 6 bottles a day, which is quite expensive. So I mostly stick to isoflurane and sevoflurane. Sevoflurane has a higher potency, by the way, and we use a lot sevoflurane in the OR, for example. So when we are going to talk about volatile anesthetics, we have to talk about the MAC value. What is it? The MAC value is the mean alveolar end tidal concentration of a volatile anesthetic that prevents skeletal muscle movement response to a surgical incision in 50% of the population. So that sounds crude at the first moment, but it was actually invented or set up in the 60s, where we needed a comparison between the different volatile anesthetics and their potency. So what you can see here, the lower the MAC value, the higher the potency. So isoflurane is double the potency of sevoflurane, for example. So the consumption in inhaled sedation will just be half of it. And a MAC value decreases with patient age, which means the older you are, the less you need. And neonates, they have to have a lot. We have to give them a lot in pediatric anesthesia to sedate them. MAC decreases with body temperature in pregnancy and anemia, but also with administration of other drugs and opioids. The duration of anesthesia and the administration does not really influence the MAC value. So it means even if you use it for 2 days, 1 week, or 2 weeks, the MAC value will not change at all. If we look upon inhaled sedation, we first have to see how does it work to give IV sedatives. IV sedatives, as you can see here on the left side, is usually administered by vein. If it's a vein or central catheter, it doesn't matter. It comes into the blood, it's distributed. The site of action is actually the brain with a receptor interaction. At the moment you want to stop your IV sedatives, you are really highly depending on the metabolism, because they have to be metabolized hepatically and to be excreted by the kidneys. That is different in inhaled sedation. The uptake is not intravenous. The uptake is by the lung. You inhale the drug, and it's highly depending on the inspiratory fraction you're giving to the patient and your alveolar ventilation, which is the ventilator setting, actually. So the intake goes from alveolar into the blood. It's depending, of course, of alveolar blood flow, lung perfusion, and the blood solubility itself. It's distributed again to the brain, where we have a complex receptor interaction. But at the moment you stop your drugs, it's not that they are really metabolized and depending on hepatic function, or they are excreted by the kidney. They go vice versa, meaning from exhalation, we eliminate our drug and we get rid of volatile anesthetics. And this is highlighted more here on this slide when you look at metabolism. On the right side, you have our usual IV drugs, propofol, dexmedetomidine, and midazolam. I learned that you use a lot of midazolam in Indonesia. And we have to say for midazolam, for example, it's up to 60% depending on hepatic metabolism. We even have an active metabolite, and if we have any impairment from the kidneys, we struggle to get rid of the drug and to wake up our patient if they had a prolonged administration over days or weeks. That is completely different when we use volatile anesthetics. Isoflurane should be the drug of choice because its hepatic metabolism is only 0.2%. With sevoflurane, we have a metabolization up to 5%. What is actually degraded are fluorides, and fluorides have been connected to produce hepatic insufficiency from a drug that is called methoxyflurane in the 70s. So that is not the whole story. I mean, we have been using sevoflurane in Germany for a long time, but our guidelines in Germany have restricted the use of sevoflurane for fluoride levels up to 25 Mach hours, which can be transferred to inhaled sedation of half a Mach, like 3 days, a usage of 3 days, and then switch to isoflurane. Isoflurane is not restricted in time for usage in the ICU. And we always have to think that we are not dealing with healthy patients. We are dealing with septic shock, for example, septic shock where we have a fluid resuscitation, altered protein binding, organ dysfunction, unstable hemodynamics. So what happens to sedatives and opioids? We need a longer time to clear our drugs from the blood. We have an increase in distribution and a higher context-sensitive half-life time, elimination half-life time. So this is why we think inhaled sedation or volatile anesthetics can be part here. What are potential adverse events? The list is quite big, although I have not really seen that in 16 years usage. I have not really seen a lot of them. Usually we see hypotension and sometimes tachycardia when we have higher concentrations of volatile anesthetic. This is an effect you can even see with propofol if you use it in higher dosages. So we might have to increase catecholamines. Respiratory depression is something, I mean, we want in the OR, but we have learned that there is an earlier spontaneous breathing in our critically ill patients in the ICU. I would not really recommend to use ISO or sevoflurane in neurological or neurosurgical patients when I don't have any monitoring of intracranial pressure. If you have a monitor and a probe in place, then of course it's possible, and many hospitals or ICUs in Germany use it, but only if they can measure it. Otherwise, you could do harm with an increase of intracranial pressure in your patients. Malignant hyperthermia, the MH, is actually the only contraindication not to use volatile anesthetics in your patient. This is a genetic disorder from special receptors in the muscle cell, which comes to a muscle breakdown, to severe acidosis, hypocarbia, cardiac failure, and finally it has a very high lethality or mortality. The good thing in this is, in contrast, for example, to the PRIS syndrome, the propofol infusion syndrome, that we have an antidote. It's called the dantrolene, and usually all anesthesiologists, they know about dantrolene, where it is stored. So whenever you are performing inhaled sedation on the ICU, just shortly check where you can find your dantrolene in your department. How can we give volatile anesthetics in the ICU? You already saw the video in the very beginning. So to come back to the state before the millennium, it was only that we could transfer anesthesia machines directly to the ICU and bring a vaporizer technique to the patient, or to plug, sorry, something happened, or to plug a vaporizer here in, you can see here in this picture, in the inspiratory limb. But then you can imagine that consumption of the volatile anesthetic was very high, because everything that was delivered to the patient was going out by the exhaust. You had a high consumption and high concerns about environmental pollution. So it was from the millennium on that we had some kind of a reflecting system, and this reflecting system I got to know in 2006, and ever since I've been using it. Now in Europe, we have even gained approval for Sedaconda, the device and isoflurane together to use in the ICU. Just to give you some more explanation, everybody was seeing the video in the beginning. So we have on this side here on the left side, the white piece for the ventilator, and on the other side, the endotracheal tube of the patient. What is inside the anaconda? there's an HME filter. Just imagine that Anaconda is in an HME filter and you put it in the same place. And we have carbon fibers where we have a reflection of our gas. So whenever I give gas through this rod that you can see here, it's called a vaporizer, and you give, for example, sevoflurane or isoflurane to the patient, and it's coming back in expiration, 90% is stored here in this activated carbon fibers and reflected in the next inspiration to your patient. So this is how it works with this anesthetic conserving device. In Germany, we have been using inhaled sedation for a quite long time. In 2010, we have first had volatile anesthetics in our German guidelines. And these are the recent guidelines. It said 2020, actually it was published in August 21. And as you can see here on the algorithm, so this is my first lesson to you in German. Okay, what does it actually say? It says, is there any indication of sedation? Then you should have an aim where you want to go to in sedation. You choose a ROS score like -1, -2, and -3. And then the first choice is propofol and analgesia. The only option that you have as an alternative is inhalative sedation and analgesics. The midazolam is no longer included in this algorithm because we have come to understand that it produces delirium and it has a prolonged wake up. So it usually is only bolused if you use it, but no longer used continuously. So what it says in the guideline is actually propofol inhaled sedation or a polypragmatic approach can provide deeper sedation. Polypragmatic in this context mean that you use like propofol, you add ketamine, you add clonidine, or you choose dexmedetomidine or even midazolam, but not continuously. So this is the only choice we have at the moment, which is recommended in our patients, and inhaled sedation as an alternative. So this is the SOP from my ICU that has been developed, I don't know, years ago. It actually says, okay, if a patient comes in either from the OR or the emergency department, and there is an indication of sedation, we have to see if that is a short-term sedation, then we would stick to propofol. We wean and extubate the patient. If that is not possible, or we judge this patient to be long-term sedated longer than 1-2 days, we start with a sulfentanyl as an analgesic, and then have a choice between propofol and isoflurane. And isoflurane is usually started at 3 ml per hour and sevoflurane 5 ml per hour. We restrict the sevoflurane for the fluoride problem as to 3 days. So usually all our patients that have any problem with the lung, with oxygenation, or we see that they need to have a reoperation, we have as the first choice the inhaled sedation. Propofol in Germany is restricted to 7 days and only in a dosage up to 4 milligrams per kilogram per hour. All the others are only co-sedatives or palliative care. So which patient groups have been studied for inhaled sedation? And I'm only going to present some of them because I don't have that much time to really explain everything in detail, just that you get to know what has been studied. This is the so far biggest study, a randomized controlled trial, where they were looking at patients being sedated with either isoflurane or propofol. This is a non-inferior study that was undertaken in Germany and Slovenia. And we actually started here as an outcome parameter, the time to wake up. There was a wake up every morning in the patient. And what you can see here and what you expect on the first day, there is not really a difference. And this is what we expect in our patient. But already on the second day, you see a difference that is still in minutes. But you, unfortunately, this was only an evaluation period of 48 hours. but you can see that something is happening if we think of a critical care patient. Spontaneous breathing in the setting was more frequent already on day 1. And what else did this study reveal? We were seeing that you can see here from the graph that we had lower opioid dosages when we used isoflurane. This is something that has been reported in many studies before, smaller studies. And even when I started, I saw it in cardiac surgery patients that they needed up to 1 day after sedation, they needed less opioids than in the other group. So the more interesting thing for me as an intensivist is what is happening if I use inhaled sedation for longer times. And here is a study from the Karolinska Institute in Sweden looking upon 40 patients suffering from pneumonia, and they had sedation over more than 4 days. And this is where it becomes apparent, this huge difference and in verbal command after stopping the agent and being extubated. With isoflurane, everything is around 10 minutes. This is what we know from the OR as an anesthesiologist, that they usually wake up very, very quickly and you can extubate them within 10-15 minutes. So with midazolam, we are here at the extubation time of around 100 minutes. What other patient groups have been studied? This is one patient group that there are several studies on post-cardiac arrest with the targeted temperature management, going down to 33, 34 degrees centigrade over 24 hours after resuscitation. And this study was undertaken in Berlin at the Charité University, and it was actually a retrospective analysis. And they were dividing the patient matched pair to either an IV strategy in ICU or a volatile strategy and sedation. And what they saw, if you have a look on the right side, that you could have a shorter ventilation time of 4 days when you used volatile anesthetics compared to IV, and that the length of stay in hospital and in the ICU was much shorter, which is around these 4 days. So if we think to have a patient earlier out of the ICU being extubated and then can bring in other patients, we are always running out of ICU beds here nowadays with the COVID pandemic, but also with other patients coming in, that would be quite reasonable to use inhaled sedation. How about mortality? Mortality has only been studied here in this retrospective analysis that was made at patients with a septic shock. They all suffered from sepsis, and they either were getting an IV regimen for sedation with midazolam or propofol or isoflurane. What you can see here on the left side is the possibility to be discharged from hospital. That is 63% when they received isoflurane and only 40% when they received IV sedatives. And then they had the study group had a look at the mortality, and they saw that not only at 30 days they had a difference between the two study groups, it lasted 90 days and even 1 year, where they had a difference of 20%. So it seems as if the inhaled sedation is really supporting our patient in the long term to have less mortality and to have earlier discharge from hospital. So to bring this here together, what can be potential benefits in our patients here? We know that inhaled sedation has a short and predictable on and offset when we use volatile anesthetic. It's organ independent, meaning metabolism and elimination. We already have a long experience with volatile anesthetic. More than 40 years we've been using them in the OR. As anesthesiologists, you're really accustomed to use them wherever you do general anesthesia. We know that we can spare some opioids opioids, which could be beneficial in the gut motility and in nutrition of our patient. And we have very well-known adverse events. For the first time, it comes to a measurement of concentration at the bedside. Usually with midazolam or with propofol, there's no chance to measure a concentration in the blood. I mean, this would take a long time to put it to the lab, and the patient is already in a different clinical state. So we can measure gas concentration and have an idea how deep the sedation is. And there might be potential benefits and outcome, which I tried to show you, although we are lacking at the moment some more randomized controlled trials. So I would like here to bring you a patient case that you can imagine how it looks like in my ICU and which patients you are sometimes facing. I have many of them. I just chose one to get you a good idea. So this is Mr. Giuseppe, 64 years old, and he had a gut perforation and peritonitis. He was in the OR. She already had problems in the OR because he suffered from a COPD. And we had high inspiratory pressures during the operation. And then he was referred to the ICU. We started with propofol, and then within like 2 or 3 hours, we had the problems that we had high pressure. This patient was struggling at the ventilator and was sure that he had to have a second look operation. He was in sepsis, and he had a pre-renal acute kidney injury. So this patient was set on inhaled sedation, and then we could really resolve his illness and sepsis, and he had a prolonged weaning. So now we see him here in day 11. The weaning was difficult the 2 or 3 days before because he showed faces with broncho obstruction. He was always agitated on arousal. So we kept him on a RUS -3 to -4, and now it was a little bit more like a RUS -2 to make him breathe and to awaken him. So I will shortly start this video that you have an idea. You see here the setup of hemodynamics. You see the concentration of isoflurane here, entirely 1613, and the MAC value. Then you see here from the ventilator setting, he's on a spontaneous CPAP breathing, meaning spontaneous and a pressure support, only 30% of oxygen. And we try to wean him constantly, and he was actually extubated 1 day later. This is the setup at the ventilator that you might have seen in the video before. It's connected to the exhaust of the Drager ventilator and a scavenging system. We use 2-in-1 ventilation tubes here. We have the Anaconda here in place. You can see here the line coming to the rod where we administer our volatile anesthetics. Here is the measurement of our gas concentration. And in this patient, we use nebulization, salbutamol, for this bronchoconstructive things. And we try to wake him up. So he is still in a -3 phase here. He got a bolus before. And you can see here as well that we use a closed suctioning system that you can see here on this side with a green swivel here. This is how it can look like in your ICU for these patients. So it was really hard to extubate him. So we left him breathing, going down with a pressure support, and then woke him up very quickly on the next morning when we were sure that he was doing good and he had recovered. And with his permission, I could show you this video to get you a good idea. Okay. Last part now, can inhaled sedation be used in ARDS and COVID-19 patients? Of course it can be used, and I use it in all ARDS patients. We know that volatile anesthetics have anti-inflammatory effects. We know that from the lab and from animal studies. that we have lower levels of interleukins. And there is one study that has shown that it can be used very nicely in ARDS patients. This study is coming from Clermont-Ferrand from France. It was a comparison between midazolam and sevoflurane, and only a duration of 48 hours was set from the ethical committee. But what you can see here is a primarily endpoint. We have the oxygenation index, the PaO2 versus the ViO2, the fraction of inspiration. What you can see here on the left graph, that after the administration of 1 day of inhaled sedation, we're going to have a better oxygenation index that lasts even over the period of not giving inhaled sedation. So this is what we often see in our patient. We use it a little bit like opening the lungs in the first 2-3 days. We use volatile anesthetics. And as a secondary endpoint, they use this S-rate. What is S-rate? S-rate is actually a parameter that we use to show a damage of epitalsis in the alveolars. So what you can see here, that after 2 days of administration of sevoflurane, we had a lower S-rate, not only plasmatic, but also in the alveolar bronchiolar alveolage in this patient. So it seems that it's not only having a better oxygenation, but preserving more the lung on the inflammatory level as well. Well, with the pandemics, I'm sure you were seeing as well many COVID-19 patients. We did not really have to change our habits because we had learned so much from inhaled sedation, how to handle the setup, how to disconnect at the ventilator. And we were using volatile anesthetics so much in this period, and we still do. We have like 2 to 4 patients on the ICU with COVID-19. And there are now emerging more and more studies to show that inhaled sedation can be used in these patients. And you have to think about it because it's an extra option and an alternative, even if you're running out of propofol. So this is a study coming from Germany with 20 patients, and they were looking at isoflurane versus propofol sedation days. You can see it here in the graph. The setup for these patients was to plug in the anesthetic consuming device, as I showed you on the Y piece where the HME filter is. The colleagues saw that when they were giving isoflurane, they had 1 point more deeper RUS score than with propofol. And they had deep sedation in their patient. You can see a very prolonged sedation time being on the ventilator here. What they experienced is that they could spare neuromuscular blockage. We usually in our ICU and in many German ICUs do not use regularly muscle relaxants. We only use them at the moment we prone them, and patients are in fear to have problems and press against the ventilator for oxygenation. Usually we don't give it as a continuous administration, it's just bolus. So they saw that with inhaled sedation, they even could spare this muscle relaxants, and they were using less polypharmacy, not adding clonidine or ketamine, and less opioids were used here. They had several patients on the ECMO therapy, 9 patients on ECMO, and they saw when they were using ECMO, they could halve their dosage of isoflurane, going down to 3.5 ml per hour. And there's another study coming from Italy, Monza, where they were using inhaled sedation during ECMO and COVID-19 ARDS. They had, again, a very long period of ventilation. Isoflurane sedation was started on day 3 of the ECMO support. And as a mean, it was used in 7 days and 1 week, but it ranged up to 38 days. This is our experience. We use it as a prolonged sedative. Even in weaning, we use it to wean out the patient. And you can see here on the right side that we could spare opioids, neuromuscular blockages. The setup for this study or observational trial was that the anaconda was not plugged in here at the Y piece where you expect it as an HME filter. But as they had really low VTs under 200 mL, they took the anaconda in the inspiratory limb and used a heated humidifier. This is possible and it's approved, absolutely. It's even used in children where you have low VTs. It's only that your consumption will be higher. You can see here the consumption of isoflurane was in a table 12.5 ml per hour because you are losing your gas again from the expiratory limb here and from the exhaust going to the gas scavenging system. But the setup is possible and it works and it's used in children and in ECMO as well. So to come to the end, a quick run through inhaled sedation and my experience in the ICU. Volatile anesthetics are nearly ideal sedative with a very long history, not only in OR, but in German ICU guidelines as well. The Sedaconda, meaning the device, together with isoflurane, has been approved lately, and it's the only approved therapy at the moment in Germany and in Europe in general. And I hope that I could show you several reasons to use inhaled sedation. It's not only for pharmacokinetics and clinical properties of the volatile anesthetic, but you can see faster wake-up and extubation. You can use the bronchodilatory effects of volatile anesthetics. And this might lead to a shorter length of stay in ICU and improve survival in our patient. We have less opioids, and it's very good in using it in ARDS and COVID-19 patients. What you need, and I think everybody saw it on the first video at the beginning, it's a training on your ICU. It's a different concept how to give sedatives in the ICU. Everything is usually IV. So this is for the first time where we have another concept. You should train your team, and then I'm sure it might be an option for you for the future as well. Thank you very much for your attention.
Thank you.
I'm open for any questions, and I just stopped my presentation that we can go back.
Yes.
For the full screen. Thank you.
Thank you, Christine. Interesting, excellent presentation. Thank you for your sharing.
Thank you
this will be
for the invitation.
Very nice for us and interesting what we can do based on what we are doing that already Dr. Bambang started telling, and you coming in there, the benefit of the drugs, the inhalational drugs. Of course, there's another opening of the textbook in the past that we didn't use for intensive care, but only on the anesthesia. And it's very interesting. It's very interesting. And as you said,
it's a new option, perhaps, because sometimes you feel like you have a difficult patient, you cannot sedate him, you're having problems, and then you put like a multi-drug cocktail to him, and then when everything is resolved, you stay there and you wait. And you wait, and the wake up is not good, and then he's perhaps in delirium. So it opens up new ideas in the ICU. And as the drug is already there, I mean, it only needs a device. You as an anesthesiologist, you know it very well that it can be used easily in another setting.
Vielen Dank nogmaals. And I'd like to talk to the audience so they can start shooting you and Bambang about more questions. Teman-teman sekalian, kita sudah dapat dua pembicara yang jelas mengatakan dasar-dasar pemakaian sedasi, kegunaan sedasi, dan apa yang selama ini kita lakukan sampai fase-fase terakhir ini, kita sebetulnya tidak ketinggalan. Gas anestesi itu juga ada dari dulu, Dan yang terakhir sudah dikatakan oleh Kerstin itu cukup baik, karena yang dilimited untuk di ICU. Limitasinya sekarang adalah tools-nya, alat-alatnya. Itu yang nantinya teman-teman sekalian tentu berhubungan dengan distributor di sini untuk berbicara dan lingkungan rumah sakitmu untuk mencapainya. Karena batasan-batasan dan keperluannya sudah ada. Saya sudah lihat tadi pertanyaan-pertanyaan yang diajukan kepada Dr. Bambang juga sudah ada, ya. Tapi ini ada pertanyaan buat Dr. Kerstin juga. Saya kira Dr. Bambang tadi sudah jawab pertanyaan tertulisnya ya, yang 2 pertanyaan sebelumnya. Sudah masuk tadi kayaknya ini. Jadi dia Kristin, saya ajukan dulu yang ini sebentar ya, bro. Thank you for amazing presentation. My question, this question comes from our colleague Yasmin Halim. My question is, have you mixed volatile inhalation in long-term patient in ICU?
What do you mean by mixed?
He is telling xenon and isoflurane as concern of hepatic effect due to prolonged isoflurane. Danke. Well, I like to invite Yasmin Halim actually on the screen, so we can see your face and talk straight to us. Bagaimana, admin? Adek?
Iya, dokter, silakan.
Boleh?
Iya, silakan, dok.
Dokter Halimnya? Dokter Yasmin Halim?
Boleh dijawab answer live boleh oleh Dokter Kerstin.
Okay. Dear Christine, you can lively respond on this. We
Yes.
can't directly put her face on this, but the question is real coming from her.
Okay, as
The
far as I understood you, they are asking if I can mix like 2 agents together and if
Correct.
xenon is possible. Well,
Yeah.
xenon, it needs a special ventilator to
Yeah.
administer xenon. So, I mean, that has never ever been used. Even in Germany, we have given up xenon because the technology is not that good. To use it at the bedside, I have actually no experience on that. But what you could do is not mix agents. I mean, nitrous oxide is something we don't use anymore for the last 15-20 years in Germany. We don't even have a means to administer it continuously in the OR. It's shut down in many places. So what you can do is you can switch. I mean, I'm not using 2 volatile anesthetics at the same time because that is not reasonable. What I often do, I use the bronchodilatory effects of sevoflurane 3 days. If there's an ARDS, a COVID-19, someone who's suffering from severe oxygenation and bronchospasm, then I use it in higher dosage to open up the lung 3 days, and then I just switch to isoflurane because isoflurane is not restricted. There are hardly any fluorides, no really potential problems. And for hepatic function, it does not really interfere. We know that we can potentially have 3 acetyl acids, but that as the metabolization is 0.2%, there's one report in the PubMed on it where it's not absolutely clear if it comes from isoflurane. So we use it as long as the patient needs it, and we switch directly. When the syringe is finished with SIBO, we just half the dosage, put the new syringe with isoflurane and leave it running. We mix it in that period. That is like, a mixture like 2 hours on the ventilator, but we don't mix it normally that you have 2 trucks coming. No, it's not reasonable.
Excellent. So, Dr.
Yeah.
Yasmin Halim, you got a clear explanation for your first question, and you based that for prolonged hepatic failure based on isoflurane. There is no data actually that with this concentration used that we have. Yasmin, you want to put your question straight away, please? Silakan, Yasmin.
No, thank you. That has been clear for me. I'm feeling thanked, Frau Kristen.
Oh, thank
Yeah,
you
so
for your question. Very
good.
interesting. Yes.
Yeah, it's an interesting question. Now, Dr. Bambang, did you come into the two questions actually already given before by the colleagues? Did they agree?
If it is answered the question, then I would like to ask to Dr. Kirsten, but
Please.
As you have shown in your slides, the using inhalation anesthetic may increase the oxygenation. But what about the mortality? Because increasing the oxygenation, it's not always also decreasing the mortality.
Well, the thing is, usually you're a little bit like standing at the
In
wall.
COVID, I mean, yeah.
Yeah, standing at the wall, and you have like oxygenation, the oxygen of 80, 90, 100%. So you first have to resolve somehow your oxygenation. And if I think I can do something good, I would use it for the first moment.
Agreed.
We don't have any data at the moment for the outcome of COVID-19 and health sedation. There are several studies, randomized controlled studies going on, but they haven't been finished and they are not published. So we don't know. It's only, for me, it's more or less like something practical. I see it in my patient.
Yeah.
I use it. I see that it works very well. And I'm not using midazolam or propofol on a long term because I experienced that it doesn't work very well. But for mortality, we do not know. No.
I think if you can do a multi-center study, and it turned out it's also decreased the mortality, I think it will revolutionize the management of the severe COVID-19 patient.
Yeah.
And I think it's very, very interesting.
It's very interesting, and it's interesting that even in the news in Germany, there was at the beginning, we had a spread of news with the pandemic, and every time they showed the ICU, you could see the anaconda in it. It was amazing for us to see that every evening in the news, it was like, oh, another anaconda. So this is how, I mean, we have been using it for 15 years now in Germany, it's proved. And actually, we had other ICUs have a shortage of propofol, and they had to find a new strategy. And then suddenly they came up with using anaconda because they were so familiar. We have 2/3 of our ICUs are run by anesthesiologists. So we are very familiar in using volatile anesthetic. That is not new for us. It's just we are not using high concentration as high as an OR. So why not? Just to try it.
As an anesthesiologist, it means we have one weapon more to fight against the COVID-19.
But it's not only a weapon, it's personal option, I'd say. Weapon is only like, ooh.
Yeah, probably the last word that you said, another option, yes.
An option.
But in the heavy attack of COVID, we need weapons. That was the moment.
You are absolutely right. I mean, yes.
Christine, actually, you are telling about isoflurane. And you started mentioning about desflurane is not useful for that in the ICU. That's very nice because those three drugs are in the market everywhere in the world. So you eliminated it already scientifically. And now coming back to isoflurane, you just make it sharp. It's for limited period and not sevoflurane and isoflurane. You should make your choice based on your renal because you are using your pulmonary system. That's what you said. And now the question of Bambang coming there, how secure can we play this on septic patient, moving from the COVID to the septic patient by isoflurane? What is your experience? How long was that? And is that still on that low dose?
Septic patient, apart from COVID-19, you need a lot less of concentration. It's usually half a mark going up 1.7, not really more. You can even have them in light sedation if they don't need deep sedation, like 0.3, 0.5. So around half a Mac, I use it. And the investigation, most of them had been on sevoflurane. Sevoflurane, an anti-inflammatory effects. Isoflurane is now being studied in several studies for the same effect, but from the animal labs, they have all used sevoflurane. So we are not sure. It's usually a class effect that you can see even in pre and post conditioning, but it's mostly studied for sevoflurane. So septic patients, we usually include them in different studies. It's just a study, the outcome study with a mortality where they had septic shock and an Apache scores more than 42. So these were these patients. I use it a lot in septic shock because I usually don't have to give so much propofol, and we have less hypotension when we use and start using isoflurane on our patients. So I usually always use it when I have a septic shock or hemodialysis running, for example, because I know I have problems, midazolam and propofol, and we usually stick to the isoflurane because it has a high potency, there's no real interference, and we think that it might have an extra anti-inflammatory effect. There had been studies for antibacterial effects as well, but that is not still not on a trial for humans. It's still staying in the lab at the moment with rats and dogs, and they are looking at antibacterial effects. So it might be that we see in the COVID-19 trials that they have less super infection. If that is coming, although I often see super infections as well. This starts at day 11, 12, 13, suddenly it starts that you have secretion. Usually they are very dry in the beginning, they don't have secretion, and then suddenly something else comes in, like a super infection on Pseudomonas or anything else. And we have to see, because there are still randomized controlled trials lacking. It's only something we see from other animal studies or other investigations.
Okay.
Do you think it would be useful in cytokine storm in COVID-19?
We use it. We actually use it. I cannot prove it. I cannot prove it, but on the background of the Chambon study, and there are other studies on interleukins, I think I'm on the good side.
Hopefully.
Yeah, but the thing is, it's something, it's our experience. We start something, it works very well, but still everything has to be shown in randomized control.
Yeah, that's right.
And sometimes we have retrospective, we have animal, we just have a small cohort of patients. I mean, 20 against 20, that is not something where you can refer to any other patient. So we are studying and we are learning not only from COVID-19, we are learning inhaled sedation and ARDS and septic shock as well.
Well, Kristin, so you are mentioning now that on septic patient or COVID, or you already share much, but on septic patient, you mentioned an Apache 40. By using those volatile inhaled drugs, how many days do you need to reduce them to becoming to low 20, 21, say the Apache? Is that 2 days?
And depends actually on the patient. I mean, if we have a lot of abdominal, dressings, abdominal surgical patients,
Yep.
they sometimes have to undergo a second or third look, and if they resolve it, then I mean, then it's going to get the Apache score is going down. That's for sure. But I cannot refer it to handheld sedation. That is going far too much to do any judgment on that, really.
Yeah.
I use it in this patient because I have a very good experience, and we think that we're going to do good in our patients. And propofol always can be linked in higher dosages, and they get accustomed to the drug. We have to have higher dosages, and I fear to have a PRIS syndrome, which is, I mean, sometimes you cannot resolve it. So, and midazolam for us is not an option in Germany, so no.
So that German option about the last drug, is that closed or you limited for only 24 hours or 2 times 24
You
hours?
mean which drug?
Midazolam?
Midazolam only as a bolus. It's not restricted in time, but it says no continuous administration.
Okay.
It means you bolus it. So when we usually have to have a second or third drug, we use a lot of clonidine, alpha-2 receptor agonist, and then we would add ketamine. This is what we often do. And then we stay with the propofol and we play. Usually, if you have a patient, he's in a severe phase, and then he's going to recover after days. So where you don't need deep sedation anymore. Either you tracheotomize him and leave him breathing and wake him up, or the disease is resolved and you can have a lighter sedation. Then we have like 7 days propofol. We add other agents, and then we get rid of the propofol.
So you combine the ketamine and dexmedetomidine sometimes.
Yeah, sometimes.
For longer.
It's not on a normal, it's not, we first start either propofol or inhaled. Inhaled, usually we don't give other things. It was something we experienced in COVID-19, where we had to add ketamine. And usually during weaning, we add clonidine, but usually we don't midazolam is not really an option.
And the clonidine, Christine, is that in titration or in a bolus?
No, it's a running continuous.
It's a running continuous,
yeah,
like the ketamine.
Yeah, absolutely. Yeah, like the ketamine. We sometimes we bolus.
Yeah, missing.
Keep it running like 30 to 90 micrograms per hour, whatever the patient needs, and depending on bradycardia, of course.
You know why I ask about these 2 last drugs, ketamine and clonidine? It's a familiar drug here in the country and all over the hospitals. Dex is not always available.
No, it was so expensive in Germany. We're not high users on dexmedetomidine either.
So if your experience you share now about inhaled drugs to use to combine, probably there is an opening to combine with those drugs that are available in the country. Things like that, what I mentioned. Yeah.
But often you don't need it. It's not often that you can absolutely combine it, but often it's not needed.
I think my colleagues in the audience actually want to mention that, because a couple of mentioned, we only have this, but which one should we combine? We have to drop midazolam, but and propofol is in the neighborhood, is always available, but yes, the expensive one, not always. And your latest drug, what you share to us today, is not that cheap because of the tools that should come, correct?
Yeah, absolutely. The truck itself is the cheapest ever.
Yeah.
I mean, you have like, I mean, I only can count in euros, but it's usually 10 to 15 euros a sedation with isoflurane. This is the cheapest ever, but it's the device that you have to use together. But we always see it in a DRG context, like having 1 day less in ICU is like 2,000 euros less. That's what we are. We are counting. We are not counting on it, meaning that we are counting the device more or less and pay an extra salary for the device. We have a whole concept of a day where it might fit in. So to have at least 1 day less in the ICU is, I mean, we didn't talk anymore. That was a concern in the beginning 16 years ago, but nowadays it's because we know that we are on the way, on the right strategy. We're convinced.
Dokter, ini ada yang raise hand, Dokter Juwita Badani dan Dokter Sylvia Ruth Alisana Baban.
Ya, silakan.
Dokter Sylvia, silakan kalau misalnya mau bertanya, atau Dokter Juwita, silakan mic dihidupkan.
Kepada siapa?
Dokter Juwita, silakan.
Pertanyaannya, silakan. There are another 2 questions live. Christine, we are waiting for the persons to come in.
Okay.
Silakan. Siapa, Dok?
Dokter Juwita, tolong di-unmute dulu, Dok.
Mana dia?
Dokter Juwita, silakan. Dokter Sylvia, barangkali.
Udah di-unmute?
Dari kami sudah, tapi dari sananya, Dok. Belum ini.
Belum dibuka?
Ya, dari sana belum dibuka.
Apa pertanyaannya?
Malah nggak jadi nih.
Nggak jadi?
Sylvia, iya, handnya malah kebawahin.
Oh, dikebawahin. Oh.
Dokter Sylvia, silakan, Dok.
Silakan. By second thought, they stop. They stop raising their hand. Okay.
Okay, I would like then ask a question. What about using IV route?
Using?
IV route of administration. Intravenous. Using inhalation anesthetic through IV route.
Okay, first of all, you cannot use it because you can never interfere it because it doesn't have a lure lock. It doesn't fit to the central line with the anaconda, so there is no concern that a nurse might connect it. There had been investigations, but years ago, to use it directly intravenously. And I think there are still some attempts to develop something for the future, but it's not something, I mean, the problem is already that the material, isoflurane, volatile anesthetics, they melt these plastics. I mean, the plastics of the catheter, they are not made to be used. You use to have special plastics like the ventilator plastic. So that is not a concept that has been resolved in the last 20 years. And it's nothing I can at the moment recommend in any means. I mean, there is a safety issue. Okay, lure lock doesn't fit at all because we are fearing that somebody's just injecting like propofol, you know.
Because some decade ago, I remember some of us using ether intravenously.
Really?
Yeah.
How did you use that? That is an interesting thing.
Yeah, we must lower the temperature of the ether and giving it through the IV because it's volatile, highly volatile agent.
Yeah.
That's some of our colleagues in Jakarta, I think they use IV ether
by that time.
Okay.
Yeah. But only for some months, then disappear.
Okay.
Because I think it's probably technically it's difficult to.
This weapon, I don't know.
Because if it can be used IV, maybe using
Maybe,
animal
but-
first.
Yeah.
And,
Yeah, but always think that you have like, I mean,
yeah,
it's liquid and you
it's not
have
simple.
to have like bubbles, and I'm not sure what is happening in the vessels. If that
Yeah.
is a really, I mean,
Yeah, of course.
we know that it's going out from the lungs, even if it's injected intravenously, that's for sure. But I'm not sure.
Dear Bambang, dear
Yeah.
Kerstin, dear
Hmm.
audience, actually, we can
2
stay
hours.
till night, and for you, Kerstin, it's still noon, right? Yeah.
Yeah.
But I know and understand we are limited to 17:00 local time.
Mhm.
So, were any other hot questions that you, Kerstin, want to ask us? You, Bambang, throw in, or last audience, please. We still got 2 minutes.
Mhm.
If there are no other, actually, what you didn't mention clearly, Kerstin, most of that benefit, but you are afraid to mention the pitfalls of the studies with inhale.
What do you mean? Which pitfalls?
The other accidents
No,
Disadvantages.
and
no.
the advantages actually are, we already heard that. That the patient didn't survive, even though we use these drugs.
No, in most of these drugs that they didn't have any change in mortality, and it's not that anybody really died from using it, because the protocols were very strict, and actually we are already only using like half a mg. So I mean, there is not really. If you have a look, there were no patients dropping out from just dying from the drug itself. And if you an anesthesiologist, you know very well, like, you know, they don't really, I mean, either the condition of the patient is so poor that that the one is suffering from a septic shock, for example, and you have to have very high cortisolamines, but this is not a drug related mortality or something. But in these studies I showed, it was not a dropout, and there is at the moment there's no difference in these patients groups, you know. No.
Right.
Disappoint you on this.
No problem. I have to ask that from this position.
Yeah. Ask me anything you want to know.
Yeah.
If I can answer it.
Yep.
Feel
So
free.
to close, actually, I'm looking forward that this pandemic will
Oh,
vanish,
yeah.
to
Yeah.
see you around here in Indonesia, and that we both with Bambang can come over
Absolutely.
to
To share
to
experience, to
Ludwigshafen,
do, yeah.
because his experience was Erlangen. That's not so far.
Mhm.
For me, from Hamburg, yes, that's far north, but southwards, I was in Niederrhein, so it's easy to come over to your area. We look forward for that. Actually,
Okay.
this story was for the one of Intega. Oh no, for Lina Chua. Lina, you arrange that Kerstin will come more, not only to visit us, but to share more things. Perhaps with the organization, we can do some expanded work in this area. We have so many areas that we can do that. Thank you again, Kerstin. Vielen Dank.
Thank you very
Yes,
much
Vivian,
for this vivid
Dank.
discussion and interest. I really appreciated it.
Bambang,
Thank you.
stay healthy, stay happy.
Healthy, yeah,
See you
absolutely.
you.
soon in another occasion.
Okay, thank you to the
Thank
audience.
you to all the audience. Teman-teman semua, terima kasih.
Thank you, Dr. Rowan, Dr. Bambang, and Dr. Kerstin, as well as Lina, all of the participants. Thanks a lot for the contribution this afternoon. Thanks a lot.
Okay, vielen Dank.
Bitteschön.
Wiedersehen.
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 Schönes Wochenende.
Ja, gleichfalls. Schönes Wochenende.
Ja.
Oke, terima kasih kepada Dr. Oloan, Dr. Bambang Wahyu. Thank you for Dr. Kerstin and team. Terima kasih kepada PT Anamed Sejahtera Bagi yang belum sempat menyimak acara kami tadi, dapat menyaksikannya pada YouTube channel PERDICI Official, dan bila ada pertanyaan dapat dikirimkan ke email kami di info@yahoo.co.id. Jangan lupa untuk mengisi absensinya agar kami bisa kirim sertifikatnya. Terima kasih atas kehadiran semuanya. Mohon maaf bila ada kekurangan dalam penyelenggaraannya. Kami tutup acara ini. Sampai jumpa pada acara webinar PERDICI yang mendatang lainnya. Selamat sore, sampai jumpa lagi.
Yes.
total ratusan juta rupiah dan hingga PCX, tekan 1.1515 untuk berlangganan NFP ini, tarif 9.900 untuk 30 hari. Tekan 5 untuk...
Jalan, Pak.
Di mana?
Di rumah, Pak.
Oh, bilang Ibu, Bapak minta dijemput, terus kalian mau jalan apa gimana?
Oh iya,
Ya.
tadi bilang itu kalian mau jalan, Pak. Ini.
Ya, wes, santai nih ya.